Hi, everyone. My name is Michelle Colder-Karras. I'm an associate in the Johns Hopkins Bloomberg School of Public Health, and today I'll be talking about preventing behavioral addictions using a population approach. Here are my disclosures. I don't have any financial conflicts of interest, but I do have mixed feelings about this area. My research is focused on both the benefits and problems of gaming, and I believe strongly that video games, internet platforms, and other kinds of communication technologies can be great ways for people to connect and can have other properties that promote and support health. But I also have firsthand experience with how gaming can interfere with life, and I've seen it in friends, family members, in the research participants who've opened up in qualitative studies, and even in some of my fellow addiction scientists. As you watch and listen to this lecture, I want you to concentrate on a few things. As public health scientists, we're taught to focus on the health of the world. We're taught to evaluate evidence very carefully and how to tell what types of studies are good for understanding causation. We emphasize careful measurement. We scout out and control for bias. Understanding levels of intervention and evaluating the types of approaches that give you the most bang for the buck at a population level is what we specialize in. Now, this wheel shows the levels of intervention that we think of in public health. We can think of promoting health through primary prevention strategies and at the societal, community, and individual or family level. We can use secondary prevention to try to prevent risk factors that lead to health problems or to prevent the health problems themselves. Once we get to tertiary prevention, that is treatment and reducing the burden of actual disease, we're getting pretty expensive. Our goal is to promote health and prevent harm. We don't like wasting money. There's a limited pot of money and some things have to be prioritized. This means sometimes tough decisions have to be made based on how much harm something does and what we can do to prevent harm for the greatest number of people. First, let's quickly define behavioral addictions. Hazardous behaviors increase health consequences, and this could be for the individual or people around them. For example, drinking and driving or texting and driving. But this is in someone who doesn't meet the criteria for addiction. Addiction and addictive behaviors include signs and symptoms of addiction, such as the inability to control behavior despite negative consequences, craving, withdrawal. They include distress and/or impairment, and they have a duration criterion, like 6 months or a year. So for example, your gambling behavior is out of control. You're $50,000 in debt, you're on the verge of bankruptcy, but you can't stay away from the local casino. That's addictive behavior. Now, there are many theories of addictions and how they develop and are maintained, but to me, this one from Robert West makes a lot of sense. This is from the prime theory of motivation, which combines various other theories to show that addiction depends on the activity itself. It has to meet a need. It has to be pleasurable, accessible. It has to induce some kind of change in the individual, usually a physiological change, and it has to push out other activities. It cannot be immediately punishing, and the individual has to be susceptible to the above, and there must be a conducive environment as well. Now, let's put that aside for a minute and talk about the overarching concept of public health and population science before we return to addiction specifically. Most people didn't really know what public health was until this year. It took several weeks for the story to unfold. It was like a movie or a book, right? On the first day of 2020, a media statement by the Wuhan Health Department in China talked about an atypical viral pneumonia, something they'd never seen before. By the end of January, the WHO had declared the outbreak a public health emergency of international concern, its highest level of alarm. More and more evidence about the virus, its transmission, and its effects kept coming to light. The WHO kept asking countries to be prepared, take steps now, contain the virus. Sorry. On March 11, 2020, the WHO formally characterized COVID as a pandemic. You don't need me to tell you what happened next. As of today, there have been over 36 million cases and over 1 million deaths worldwide. Countries that took steep measures early, like China, Taiwan, and Korea, are doing better. Countries that value state and personal freedoms over public health, like mine, the US, are doing much worse. What happened? Where did public health get this wrong? Well, here's how the public health response works. We identified a threat, people becoming incredibly ill and dying from a new virus. The public health response of some countries was good. They dealt with it effectively and early on. They implemented strict measures that save lives, like wearing masks. Some countries didn't. They wavered or did not or could not implement or enforce measures. And we, are doing worse. Here's what's important to know. Public health follows a process to protect citizens' health, identifying problems, then figuring out how to prevent or control them. This process involves gathering information and evidence. Sometimes, in urgent life and death situations, decisions have to be made in the absence of evidence. Sometimes these decisions will be things that people don't like quarantine or wearing masks. The overall goal of public health is to protect the health of populations. To do that, you need to look at health problems through a population lens. Now let's see how that ties in with the principles of population science and why that's important for understanding prevention. There are several important things to consider when looking at public health through a population science lens. We'll focus on a few of these. First, the presence of disease is better seen as a continuum. Keeping in mind the continuum helps us focus on how we can shift possible causes to make the biggest difference in populations. Second, causes are not simple A to B. Even the most straightforward health problems involve a variety of interacting factors that vary from population to population. Third, prevention is usually way more cost-effective than treatment. Fourth, you can usually get more bang for your buck if you make a small change in a widely present factor rather than a huge change in a factor that not many people have. Finally, for this lecture, to really focus on population health, we have to consider what the return on research and prevention is for the population as a whole. And this might involve considering things that seem ethically challenging. Health and health behaviors exist on a continuum, and populations can have different distributions and means. So for example, population A, this is a population of young girls. We can expect that young girls don't play video games for many hours a day. The average is about 21 minutes in preschoolers. If you saw a young girl playing video games 4 hours a day or even 2 hours a day, that might be a little concerning. Little girls have way more important things to spend their time on. And even if games might be appealing enough for a little girl to want to play 2 to 4 hours a day, parents will usually take issue with that and restrict their time playing. Now, contrast that to, for example, young men. Their distribution of hours playing could be, say, 1 to 2 hours per day, with 6 hours being pretty high and none being pretty low. 2 hours might be normative. It might be a way for them to let off steam, connect with others. And young men are often aware of and able to deal with competing demands. Their gaming fits in with where they are in their lives. It may interfere from time to time, but usually not to the point where they lose opportunities or feel a lot of distress. Now you can use the same lens to look at other process or even substance addictions. For the little girl, using alcohol to change her mood would be a horrible sign. Riding an exercise bike for hours a day because she feels fat or it makes her feel not as stressed, same thing. If we see a little girl collecting penguins in her online game so she can exchange them for a chance at getting the special rainbow penguin, red flag. For the young man, most adults like to change their mental state every once in a while, whether it's through recreation, alcohol, or something else. He might be more likely to exercise hours a day to get buff or deal with stress. You know, it's less concerning than if a little girl did it. We think about that continuum because it helps us figure out how we can concentrate on preventing things at a population level. We identify risk factors, like spending too much time on a behavior, and nudge toward less time. Or we identify a risk factor that's also in a continuum, like coping or social skills, and we aim to improve them because that will improve a lot of things at a population level. Understanding causation is another really important thing for population science. Causation is not so simple in health conditions. Some types of causation are easier to understand than others. COVID is caused by the SARS-CoV-2 virus. That's why we in epidemiology use causal inference approaches and epidemiological methods to try to determine what might have reasonably caused a health outcome. These aren't always foolproof though, so I'll show you some here with the ways they can be misinterpreted or misunderstood. I'm sure you've seen some of these examples before, by the way. They're all from Reddit. First, we have temporality. A can only cause B if it comes before it, right? But if B comes after A, you have no reason to say that A caused B. It would need to also be plausible, which is our next criterion, biological plausibility. Two things can be related statistically without making any sense at all. Another thing we look for is strength of association. If two things are strongly associated, it's more likely that one is related to the other, but not always, as you can see here. There's a sneaky little alternative called confounding, where a third thing, in this case summer, causes the two other things. Drawing conclusions about causation from research is called causal inference, and only studies that are longitudinal, whether they are observational or experimental, provide good support for causal inference. But still, it can be easy to draw incorrect inferences for many reasons. Now here's an example of a simple causal diagram. If you look at this first part, it looks pretty clear that playing a lot of video games can cause problems like lower grades, family problems, etc. But if we add this mediator, time on homework, then we see that some of the effect of games on these outcomes is actually caused by the effects of playing on too much homework. Or sorry, less time on homework. Playing too much on homework. But then if we take into account a possible confounder, depression, we see that the relationship is really not that simple. So in this case, depression is causing the heavy video game play, maybe as an escape, or maybe players are looking for the social support or sense of achievement that they can get through playing. But the depression is also leading directly to lower grades and maybe family conflicts. And all of these little boxes are also subject to measurement problems. So if we don't design studies to take this confounding into account, we're not doing the kind of research that can show causation. And unfortunately, this happens a lot in behavioral addiction research. Also, the vast majority of research is cross-sectional. It can't show causes, only associations. Studies also sometimes state conclusions in a way that's not supported by evidence. So for example, studies can report significant correlations between A and B, then do a second statistical analysis that controls for confounding. When this is done, the links between A and B often just go away because it turns out there was that confounding. But sometimes the study authors will still say, hey, we showed that A was linked to B. Or a systematic review that includes the study might only report the correlation. So the better analysis, the one that controls for confounding, is ignored. This is called selective outcome reporting, or cherry picking. And this is what we found in our review of systematic reviews, which is coming out in a couple of weeks. We reviewed 7 reviews about associations between gaming disorder and depression or anxiety, and found that none of the reviews could be considered reliable sources of evidence for 2 main reasons. They all had some level of selective outcome reporting. They didn't make it clear which outcomes they would report from a study, and they tended to report only the positive links. They also all mixed measures of video gaming disorder with other measures, like measures of internet addiction. So this is the second part of population science. Nothing has just one simple cause. Even for medical things like dementia, diabetes, and heart attack, there's a causal web. Some of these things we can try to prevent, like life stress and depression, and preventing problems is ultimately much more of a better return on investment than treating them. The economic cost and the cost to society of treating these things that are all the way on the right side of the slide, stroke, dementia, diabetes, that's very, very high. Now, let's start looking more closely at that return on investment. As you can see, the population impact on deaths is very high for many disorders. Now, note the number of deaths in this slide attributable to alcohol and drug use disorders, and compare that to the ones at the top of the slide, and for example, the 1 million global deaths from COVID in 9 months. Now, we can measure burden of disease worldwide by mortality or deaths, or we can measure the burden of disease by a statistic called disability adjusted life years, which is a combination of the number of years lost to life by death and also due to disability. Now, when I was preparing this presentation, I reviewed a lot of research on gaming and gambling disorder. And even after 30 years of research, there doesn't seem to be any data on harms at a global level. There's a little bit of research in Victoria on gambling harms that uses these kinds of statistics, but even that didn't seem to find any deaths at all. So our ability to detect behavioral addiction harms in terms of global burden of disease is missing. If we work to prevent cardiovascular disease, cancer, etc., we prevent a lot of burden of disease at the level of the global population. And these things are pretty prevalent in the world at large. So we're doing a lot of good at a global level. And this is like my school's motto, saving lives millions at a time. The population impact on health caused by behavioral addictions is much less clear, but it's likely to be much lower. Now, going back to the idea of the causal web, here's an unfortunately dated slide taken from my 2015 systematic review that shows how we can think of the multiple interacting factors associated with problematic gaming in adolescence. Note that these were all taken from cross-sectional studies because at that point, the longitudinal studies were few and far between. This way of reporting results takes into account a couple things that aren't made clear in many reviews. First, it takes into account levels of association from the individual non-malleable factors, things you can't change like gender, age, minority status, to social and cultural factors like policies and country. And very importantly, it includes things that have not been found to be associations. So this addresses that selective outcome reporting we talked about earlier. If you don't see reporting of lack of associations in a review, you should be concerned. And you've hopefully read your assignments for this class, which discusses associations for a variety of addictive behaviors. So I won't go into them here, except to reinforce one concept. This diagram shows how people can move in and out of states of excessive, normal, and problematic gaming. Again, this is a bit dated, but from these longitudinal studies, it's clear that about half of the population with problematic gaming returns to normal gaming within several months. And by the way, this slide and the previous slide are reviews of problematic gaming in population samples of adolescents. So let's do a brief recap of the problems from a population science perspective and how they apply to gaming disorder as an example. First, we have measurement issues. Gaming disorder has a long history of research. There are many different ways to measure it. Even though there are now 2 formal sets of criteria, those still aren't always used. As with other mental disorders, there's a lot of overlap between the symptoms and signs of gaming addiction and of other mental disorders or life problems. And this sometimes gets mistakenly attributed to causation. For example, some scientists say gaming disorder causes depression. The longitudinal outcomes are much less clear, and there are problems with the evidence that we talked about related to selective outcome reporting. But overall, there's a lot of controversy about gaming addiction and behavioral addictions in general, maybe with the exception of gambling disorder. And there's a lot of push by some organizations and researchers to emphasize, fund, and investigate tech and other behavioral addictions. Gaming disorder especially is often referred to as a public health threat. I hope 2020 has put public health threats into perspective, but we'll see. Now, the precautionary principle has been used as a reason to put time, effort, and money into gaming disorder prevention and research. That principle says that we should act on warnings even if harms are not fully understood. That's what we talked about earlier with COVID. Some countries acted quickly and strongly to suppress the threat. Other countries didn't and had worse outcomes. Then we chose the safest options to prevent harms. Now, all we can do with COVID at this point is social distancing, masks, hand washing, etc. We can't do vaccines yet, even though there are around 50 in testing, because we don't know if they're safe. Even if we don't know the exact harms, it's the level of harm that matters here. It's the magnitude. Evidence about COVID is changing, but it's still very clear that the magnitude of harm is enormous. Evidence about gaming disorder and behavioral addictions are changing too, but it doesn't make sense to tolerate questionable quality evidence here to spend a lot of money on prevention. Why? Here's the ethical trade-off. There are many serious health conditions, including substance addictions, with plenty of evidence for their burden of disease and population health impact. That supports the need for public health and policy geared toward prevention. We've got COVID, we've got depression, we've got obesity, cardiovascular disease, cancer. For gaming disorders and most other behavioral addictions, we're using this questionable evidence to enact policies and fund more research that itself may not live up to public health standards. Not saying it's all like that, but much of it is. When the population impact might not be very high, we are not likely to prevent any deaths. We don't have good evidence in the measurements used in public health, those disability-adjusted life years, on the burden at a population level. Now to the specific question at hand. That said, how can we reduce harms from behavioral addictions? Again, let's clarify addictions and compare harms, which are health and other consequences we know are directly caused by the addiction. First, for substance addictions, alcohol addiction causes cirrhosis, nicotine addiction causes lung cancer, many addictions contribute directly to cardiovascular disease, and these can all result in death. Now here are some of the clear harms that can be directly attributed to behavioral addictions. For gambling addiction, obviously financial harm is a clear problem. For exercise addiction, we can see bone loss can be a pretty severe health outcome that can be caused by years of being underweight. And injuries like stress fractures that are compounded by refusing to rest. So for example, this guy, Jesse Thomas, who has completed the 140-mile Ironman triathlon, ran a 5K race on crutches because he had a stress fracture. For smartphone or game addiction, one severe problem is accidents caused by texting or playing mobile games while driving. And I'm proud to say that this Pokemon Go example came from my hometown, Baltimore, Maryland, USA. This guy ran into a cop car, by the way. That's why it's so funny. And for many of these, the effects may not be as much on the person, but on those around them, like this woman who feels neglected by her gaming partner. These are harder to measure and compare than deaths or disability-adjusted life years, but not impossible. So how do we put together what we know about the measurement of behavioral addictions, our understanding of harms, and what we know about treatment and prevention to put them into perspective as a public health problem? How do we consider what's best to reduce their impact on society while making the necessary trade-offs between reducing harm from these problems and others when clearly there are other urgent public health needs? How do we come up with cost-effective ways to make a difference in the lives of not just those already affected or already having problems, but all people who are at risk? And let's go back to that public health prevention framework. Our choices are considering that the harms seem much lower than other public health problems that have urgent need, and that many people probably are able to self-regulate risky behavior, we could do nothing. But even if the problem of behavioral addictions has little serious overall population level impact compared to other public health problems, we're still ignoring the very serious problems of the individuals whose relationships, work, financial situations, and sometimes physical health are seriously affected by their problems with addictive behaviors. This makes it difficult for them to get help. Treatment won't be funded, for example, and to fund research about prevention and treatment. Many researchers and countries think this is unacceptable. I do as well. We could go for primary health promotion and universal prevention, education, and dissemination. We can support communities, gamers, social media users, endurance athletes, etc., their parents and loved ones, teachers and clinicians in understanding the dividing line between healthy and unhealthy behaviors and what they can do to support healthy behaviors. We can promote media literacy, including healthy online and offline behaviors in school-age populations. We educate about drug and alcohol use, about sexual behavior. Why not include other potential addictive behaviors? We can teach young students to be less impulsive. This will help with substance use problems, improve relationships, as well as helping prevent behavioral addictions. We can teach coping skills that will help reduce stress, like mindfulness. We can teach people about depression and anxiety, how to recognize them, and what to do. We can destigmatize getting treatment. We can help children understand, sorry, having so much trouble. We can help children understand how to keep themselves safe and healthy while they learn to choose what behaviors to engage in. I know what I need. I'll sit. Sorry about that. We can work this universal approach into the school curriculum. This will help many, many things that can promote health. The money spent will have a big impact on many serious health conditions that cause a big burden of disease. And we can target those populations that might be at special risk. We can provide education and intervention to those populations, people who have symptoms of depression and anxiety, for example, to help them develop effective coping skills that don't involve relying on excessive behaviors. We can use automated screening to reach out to extreme users with personalized feedback. Hey, did you know you've spent $1,000 on this site in the last day? Or you've spent 40 hours playing this game for the past week? Or whatever that excessive level is on the continuum for that behavior. This is data that's routinely collected and analyzed by the platforms. And it's much easier for them to handle this intervention. Ultimately, the biggest return on investment will be from intervening early in development and wrapping that health promotion piece into existing programs. This would involve little additional expenditure and puts these behaviors into the perspective of learning about self-regulation and recognizing and dealing with problems early on. One approach that to me is underutilized is actually talking to gamers themselves, this stakeholder engagement approach. Now, as I told you, I'm a member of the gaming community. I still consider myself a gamer, even though I hardly play anymore unless Duolingo counts. To me, stakeholder engagement is a pretty simple idea. Instead of relying on people who have little understanding of gaming, like most clinicians, researchers, policymakers, ask gamers themselves what addiction means to them and how they can be supported in self-regulating their gaming. So I've been attending fan conventions and asking gamers. And gamers tell me that addiction causes serious social problems. They worry about their relationships. They don't like feeling out of control. What they thought were signs of addiction did not mesh 100% with the signs proposed by the Diagnostic and Statistical Manual. They talked about social problems as being a huge warning sign. And they mentioned losing control specifically related to appointment mechanics as another factor, for example. So in a second study, I asked, what are we going to do about that? Like, how do you fix it? And I heard things that are new to the literature. Our analysis showed that things like adding breakpoints, letting people set alarms, incentivizing shorter play sessions, and a host of other things were not just acceptable, but things that gamers wanted. And these can be incorporated into games by game designers. The gamers also thought that some mechanics were exploitative and they wanted them to be removed. So what does this imply for prevention? Rather than spending our public health dollars on prevention programs that may or may not work, we could do two things. We could implement prevention programs that will help with a lot of health conditions, like we talked about in the previous slide. The second big thing this implies is that the industry should encourage healthy design. The gamers I talked to identified many ways the industry could help, and we found those from talking to just a small sample of gamers. Imagine what we could learn about what the gaming community wants from talking systematically to a large group of users. And we can extend this to the social network users as well. So here are some things the industry could do. And I have to say, I'm excited because I just learned this week that there's a new group called ethicalgames.org that started this summer. It's led by mostly developers with the goal to promote healthy gaming and reduce design factors that contribute to unhealthy gaming. So some of these ideas come from the gambling industry, like labeling and age restrictions, making it clear what chances of winning are, creating and naming disorders to open up those funding streams and the opportunity to make policy decisions, and talking about warning signs of problematic use. The industry could also offer education about problematic use. It could conduct screening and refer people to treatment. And from a design perspective, keep in mind that health is a human right. And the industry could directly affect the health of its gamers and reduce the risk of unhealthy gaming through ethical design. It could remove exploitative appointment mechanics, could add breakpoints, it could add mechanics that disincentivize excessive play, like experience decay. That's when you're playing for a long time and your character can't advance as quickly because you've been playing too long. It can let us set alarms. I personally found these very useful when I was playing too much. And it could use nudges, like when your loading screen says, remember to take a break. It could also use gatekeeping measures, like forcing you to take a moment and read something about excessive gambling when you spend above a preset limit. And above all, for all behavioral addictions, stop making it cool to be addicted. Hardcore gamers are one thing. Promoting 18-hour boss fights is another. The clearest example of this that I can think of for behavioral addictions, where the promotion of an identity leads to the possibility of serious and lasting health harm, is related to exercise addiction. I'm not saying that this is the case for all endurance triathlons or for all people who compete. But when that man or woman runs across the finish line after training for months for 2 or 3 hours a day and then doing the actual triathlon, swimming for a couple miles, biking for more than 100 miles, and then running a full marathon on top of that, and the announcer says, for example, Sam Houston, you are an Ironman. Who can resist that? In this lecture, I tried to describe how my perspective as a public health scientist forces me to use a population science lens to look at behavioral addictions. My background as a gamer gives me additional insight into the problems of gamers, and I use the knowledge of other gamers that I talk to help me conduct my research about gaming. I don't have financial interests in huge addiction clinics. I don't accept money from the gaming or other industries, and I haven't built my lifetime of research on behavioral addictions. When the precautionary principle is brought up in the controversy about behavioral addictions, I keep coming back to this general quote from the WHO. The quality and relevance of available scientific information is central to the debate. I hope this lecture has helped clarify what we know about the harms of addictions versus other public health threats, and how this suggests that the best prevention approach should focus on a couple of things: wrapping interventions to prevent harms from behavioral addictions into other relevant interventions, like the promotion of coping and self-regulation skills, educating individuals, communities, and the general public about behavioral addictions, and focusing on what the industry can do to promote healthy engagement with games, gambling, and other behaviors that, in the context of addiction, can lead to serious harms. Mostly, I hope that the research on behavioral addictions will be done in the most rigorous manner. I hope that studies will be designed and reported in such a way as to reduce bias, and that causal inferences will be supported by evidence. Even though the precautionary principle has been used a lot as a reason to focus on behavioral addictions, I hope that this lecture has provided a little more clarity about how this fits into population health. And thank you very much for your time. I just wanted to take a minute to thank my collaborators and supporters. Special thanks go to my family and friends, and my funders, Hopkins, the National Institutes of Health, the VA, and the fan conventions that have worked with me to do this research. Also, you can find the references that I've used here in these two slides. Copies of these slides should be available to you. And if you'd like to contact me, you can contact me at mkaras@jhu.edu or visit my website, mkolderkaras.com, for copies of my publications. Thank you.